Good afternoon. I'm Dr. Deepti, JV, MDS, Senior Lecturer, Department of Conservative Dentistry and Endodontics, Sri Balaji Dental College and Hospital, Bharat Institute of Higher Education and Research. Today, I'll be presenting a topic on indirect pulp capping. The contents of my topics are introduction, cavity liners and bases, remaining dentin thickness, difference between the infected and the affected dentin, what is indirect pulp capping, indications and contraindications for indirect pulp capping, the material used and the clinical procedure, and conclusion. So coming to the introduction, pulp protection requires the consideration of chemical protection, electrical protection, thermal protection, pulpal medication, and mechanical protection. Liners and bases are the materials which are placed between the dentin, sometimes on the pulp, and the restoration to provide a pulpal protection. So coming to cavity liners and bases. So cavity liners, calcium hydroxide as a cavity liner, it causes dentin mineralization by activating the enzyme ATPase. It stimulates reparative dentin formation and forms a mechanical barrier when applied on the dentin. Calcium hydroxide has a high pH of 12.5, and hence it neutralizes the acidity of the silicate and the zinc phosphate cement. Calcium hydroxide dissociates into calcium and hydroxide ions. Hydroxide ions neutralizes the hydrogen ions from the acid of the cement. Calcium hydroxide is biocompatible in nature, and it is also bactericidal. Zinc oxide eugenol as a cavity liner. Zinc oxide eugenol alleviates pain in mild to moderate pulp inflammation. In low concentration, it acts as an obtudant, but in high concentration, it acts as a chemical irritant. When used as a liner, there is a release of eugenol for the first few days of setting, and therefore it is not used in a deep cavity preparation. It should not be used under composite restoration as they inhibit the polymerization of the bonding agent and the composite. Coming to bases, there are two types of bases. One is high strength bases and low strength bases. The cements which are commonly used as bases are zinc phosphate, zinc polycarboxylate, zinc oxide eugenol, glass ionomer, zinc silicophosphate, calcium hydroxide, and resin cement. In clinical consideration of a cavity base, if a zinc phosphate is employed as a base for thermal insulation, a zinc phosphate cement, it has a low pH, and however, if a zinc phosphate cement is mixed as a thick, non-tacky putty mass, this risk is negligible because minimum free acid remains. In case of GIC base, any deep area should be protected by a thin layer of calcium hydroxide paste. For amalgam restoration and direct filling gold, it is necessary to use a strong base material such as zinc phosphate and zinc polycarboxylate. In deep cavities, which it is desirable to place a calcium hydroxide liner on the deepest portion of the cavity, and this liner is overlaid by a stronger cement. Zinc oxide eugenol, it has an excellent sealing ability, bacteriostatic, and anodide action on the pulp due to sedative effect. It should not be used with composite because it inhibits polymerization of the composite. Zinc phosphate reduces thermal conductivity of metallic restoration. The cement should not contact enamel walls and cavo surface margins. Zinc polycarboxylate, it chemically bonds to the enamel and the dentin, and it has antibacterial properties. Varnish should not be used as it neutralizes the adhesion property of the cement. GIC is anti-cariogenic due to fluoride release. Chemical adhesion and GIC has chemical adhesion to the enamel and dentin. It is biocompatible, and it is also well tolerated by the pulp. The clinical judgment about the need of specific liner or a base depends upon the amount of remaining dentin thickness which is present. The remaining dentin thickness should normally be 1.5 to 2 mm, more the remaining dentin thickness, there is less damage to the pulp. Less the remaining dentin thickness, there is more damage to the pulp. So if the remaining dentin thickness should be minimum of 1.5 to 2 mm. If the remaining dentin thickness is 2 mm or more, there is little or no pulpal reaction, and there is healthy reparative dentin formation. If the remaining dentin thickness is 1 mm, it reduces the effect of toxins to the pulp by 90%. If the remaining dentin thickness is only 0.5 mm, it reduces the effect of a toxin substances on the pulp by 75%. If the remaining dentin thickness is less than 0.25 mm or less, severe pulpal inflammation or odontoblastic cell death is seen. So in this case, if the remaining dentin thickness uh, is the remaining dentin thickness is at 1.5 to 2 mm. If it is 2 mm or more, in case of an amalgam, only chemical protection is needed. So in case of amalgam, we can apply varnish. In case of composite, a dentin bonding agent is applied. If the cavity is moderately deep, that is, if the remaining dentin thickness is 0.5 to 2 mm, a base is applied, which gives mechanical protection, followed by varnish in case of amalgam, or dentin bonding agent in case of composite. In case of a deep cavity preparation, where the remaining dentin thickness is only 0.5 mm, in such cases, a cavity liner is given in the deepest portion of the cavity, followed by a base, and then followed by varnish in case of amalgam, or dentin bonding agent in case of an composite. So before we know about pulp capping, we need to know about the infected and the affected dentin. The infected dentin is the softest demineralized dentin, and infected dentin it is teeming with bacteria, whereas affected dentin is not yet invaded by the bacteria. In infected dentin, the collagen is irreversibly denatured, and hence it cannot be remineralized. Whereas in affected dentin, the collagen cross-linking still remains. In infected dentin, in infected dentin will usually be a soft necrotic tissue, and it can easily be removed using an spoon excavator, or an large round bud. The affected dentin will be softer than the normal dentin, but it will be harder than the infected dentin. The infected dentin stains with the 1% acid red in propylene glycol stains, whereas affected dentin usually does not stain. So in pulp capping, we generally remove the infected dentin, and we preserve the affected dentin in the floor of the cavity. So coming to pulp capping, there are two types of pulp capping. There are direct pulp capping and indirect pulp capping. So indirect pulp capping is defined as a procedure wherein the deepest layer uh, of the remaining affected carious dentin is covered by a layer of biocompatible material in order to prevent the pulpal exposure and further trauma to the pulp. In this procedure, all the carious tissue is removed except the soft, undiscolored carious dentin adjacent to the pulp. Caries near the pulp is left behind to avoid the pulp exposure. So, in indirect pulp capping, we should remove caries present in the walls, in the floor. The infected dentin is removed, whereas the affected dentin is preserved so that it avoids pulp exposure. So, indication for indirect pulp capping are a large, deep carious lesion near the pulp, but without pulp exposure. Uh, the tooth shows a positive response to electric pulp testing, thermal testing, and test cavity. The gingiva around the tooth should appear normal and asymptomatic on palpation. There should be no mobility of the tooth, no history of spontaneous pain, no tenderness on percussion, no radiographic evidence of pulp pathology, no root resorption or radicular disease radiographically. The contraindications for indirect pulp capping are a presence of pulp exposure, radiographic evidence of pulp pathology, a history of spontaneous pain, pain on percussion, presence of mobility, root resorption, or radicular disease present radiographically. So coming to clinical procedure, the first local anesthesia is given and the tooth is isolated with a rubber dam. We can band the tooth if the tooth is grossly decayed. The cavity outline is established with and the cavity outline is established with high piece, hand piece and the round burr size 6 or 8. So first the superficial soft infected dentin is removed without exposing the pulp. The deep caries dentin is removed with a sharp spoon excavator until firm resistance of a sound dentin is felt. A thin layer of dentin and some amount of caries is left to avoid the pulp exposure. So we should be very careful. We should remove the dentin which are present on the walls of the cavity. In the floor of the cavity, a thin layer of dentin with some amount of caries can be left to avoid pulp exposure. The cavity is flushed with saline. Then the cavity is flushed with saline and dried with cotton pellet. The potential exposure site is covered with a thin layer of calcium hydroxide, and the cavity is sealed with an intermediate restorative uh, material. The patient is recalled after 6 to 8 weeks, and history must be negative, and intermediate restoration must be intact. The biting radiograph is taken to evaluate the formation of reparative dentin, and then we have to isolate the tooth, remove the temporary filling, and the calcium hydroxide dressing near the pulp horn. The soft brownish red colored affected dentin, which was present in the first appointment, changes to a light brownish gray, hard in consistency. Remove all the soft residual debris, place a layer of protective base and a permanent restorative material. So we have to place the calcium hydroxide in the deepest portion of the cavity. Over that, base is given, and then an temporary restorative material. So it is a deep caries lesion. So initially, a gross caries excavation is done. In this gross caries excavation, we remove the infected dentin as much as possible. Caries is removed from the walls of the cavity, whereas in the floor, the infected dentin is removed and a small layer of affected dentin is kept intact to avoid pulp exposure. And then this caries dentin is covered with a layer of calcium hydroxide, and then it is sealed with an temporary restorative material. After 6 weeks, the patient is recalled. The patient should, and a radiograph is taken. The patient should give negative history, such as the patient should not complain of any spontaneous pain or tender on percussion. In the radiograph, reparative radiograph is seen for any reparative dentin formation. After 6 weeks, the cement is removed and the calcium hydroxide is washed away. The excavation of the remaining caries dentin is completed. Again, calcium hydroxide base is given in the deepest portion of the calcium hydroxide liner is given in the deepest portion of the cavity. A base is placed, followed by an permanent restoration. So conclusion, to prevent the pulp damage and to preserve the integrity of the pulp, the dentist should observe certain precaution. So first, excessive forces should not be applied while insertion of the restoration. Selection of a restorative material should be based on the physiological and biological property. Excessive heat production should be avoided by polishing restoration. Avoid applying irritant chemicals to freshly cut dentin. Use varnish or base before placement of restoration, and regular recall visits for periodic evaluation of pulp status. Thank you.